All right, guys, let's talk about multidisciplinary rounds sheets. This is for RNs to fill out. And we would like this to be started on night shift, but I want to start off by saying, before you all start freaking out, that this is way down on the totem pole on your duties, especially for night shift. I know that you guys are really busy and the last thing you need is something else to be thrown at you. So really what I want night shift to do is just to take one of these sheets for each one of your patients and put a sticker on it. And if there's any grossly abnormal things with your patient that you see on this sheet, then write that down. If you had a horrible night, or if you just have, busy day with 5 patients and the charging count and you don't get to it, that's fine too. Again, I don't want to put any more work on you, especially right now, but this is just more progress for our unit, and it's going to really help out having meaningful multidisciplinary rounds. Instead of just stopping everything you're doing at 11:30 every morning, we're actually going to hopefully accomplish something for our patients. We already did it yesterday and we're able to change some of the course of action on some patients and determine some barriers for discharges, simply because we were actually giving more information to the doctors. Okay, so notice that there's a place for the patient label up here. If you can just put a sticker on there, great. If night shift can do it, if the charge is out of counting, you can do it. If not, then everybody just grab one. If you have time, if you don't, that's okay. Day shift can do it too. We'll start with LOC. Again, only abnormals. So if the patient's ANO times 4, you don't need to write anything there. It's only if they're altered, or if they have a lower GCS, or if they have an abnormal NIH. Hemodynamics speaks for itself. If they're on a drip, just put it on there. Go ahead and include nitro, and just put what they're on and what the rate is. Respiratory, if they're on O2 at home, you don't need to put what they're on here, as long as they're not on more O2. So if they're on 2 liters at home and they're on 6 liters here, obviously that's something that you would put there. And then if they're on high flow or on a BiPAP. The pain scale, CSS 5 to 10 instead of 1 to 10. I don't care if they have a pain from 1 to 4, I care, but this is only for the people that have uncontrolled pain. So if their pain is 6 or 7 or 8, then write that down and then tell us what they're having for pain right now. For GI and glycemic, it's only out of range. So if they're diabetic and they had a blood glucose of 250 after their meal, that's fine. I don't care about that. This is more for the 400s or the 40 blood sugar, to mention during rounds. And then bowel regimen, only if they're having bowel issues, you need to worry about this. If they're not here for that, then just leave it blank. Same thing with wounds. If they have, a little scratch on their face, I don't want to know about that. But this is like a wound that might need something more than just a Meplex on it. IV fluid status, so basically how much have they been eating? Again, only if it's abnormal and if they're on a restriction diet. Critical lab values, of course, if you've had any through your shift. I don't want to know that they had a lactic of 8 3 days ago. This is literally the shift before or during your shift. And then notice that this area here is gray. So down here it says only report abnormal findings and items in the gray box. So the items on the gray box you will always report. That's central lines. A midline is not a central line, so don't include those. It's just central lines and PICC lines. How many days it's been on, where it is, and what is the indication for that line. If they don't have an indication for the line, then that line should be removed. Same thing with Foley's. What is the indication for the Foley? We don't do critical care I's and O's here. We're not an ICU. So if that's the reason for the Foley, that Foley needs to come out. We can do I's and O's in other ways. Chest tube, other drains, etc. And then the big one that I want to make sure that we work on, because I think this is our biggest opportunity right now in the unit, is mobility. Report mobility every time on your patients, because the patient might be walkie-talkie at home, and all of a sudden you come back and you say, patient's on bed rest. I want the doctor to say, why are they on bed rest? They were walking at home. and then you say, well, I don't know, maybe I should go walk them, right? So it's just to kind of remind us one more place where we need to address mobility in our patients. I haven't been seeing the hearts walking in the hallways. I haven't been seeing a lot of people really walking. This place should be, up and down with people in gowns during the day. And then any overnight events that are pertinent for the doctor to know that you think that they might not know yet. So on a patient that doesn't have anything that's really abnormal, which would be a lot of them, right? Because we know they're sick, and that's not abnormal. That is normal for them to be sick here. This is things that need to be addressed, basically. And so if you don't have anything that needs to be addressed that's that abnormal, then you're going to say, I have nothing to address. The patient is up with a cyst ×1, and that's it. And then you move on. So I'm going to post this video, and then I'm going to post with it a quick video of what the rounds should look like. We did it with some people from the hospital. So you'll have these 2 videos to watch. It should be about 15 minutes. So if you guys want to put in the Kronos book 15 minutes for MDR videos, we'll pay you 15 minutes if you watch this at home. If you watch it here in the hospital, obviously you're on the clock. So please, honor system here. And that's all I have. All right. Thank you. Bye.